All right, let's get started. So thanks everyone for joining us today. We have a live conversation with Parker Lacy of Trilogy Health Services, and we're going to be talking all about the decision to, first of all, put in place a program to protect residents and staff and consider the programs that you would deploy to do that in Parker's experience. And specifically, we're going to focus on how to, keep residents and staff safe from infectious diseases in senior care communities. So we're going to have a broad-ranging conversation today. It's very much meant to be a dialogue. I'll talk quickly through our agenda and then get into an intro to Parker for this conversation, and then we'll navigate through the entire decision-making process and program he's rolled out. It's going to be pretty interesting dialogue today. So first we'll cover Trilogy, a little bit more about the organization. We'll get into the importance of maintaining healthy spaces and how you can tie healthy spaces to outcomes for the business and for people, strategies for clinical excellence, as well as thoughts around considering a UVC program, and through the consideration process, decision to purchase and implement, and that entire flow, which was based on Parker's experience. And at the very end, we'll cover the ASHRAE 241 standard, which has just been released at the beginning of July. And so I'm curious to hear Parker's thoughts on how he's considering that and what he thinks about the senior care community, considering that for the future moving forward. So with that, intros, I'm delighted to have Parker from Trilogy join today and share his experience as VP of Facilities for Trilogy. Also something that I think is interesting for the group to understand is Parker just won an award as a healthcare hero for implementing the SHIELD program, which we're going to talk about today. It's the Business First Award, and pretty exciting. I think it recognizes healthcare heroes locally who've gone above and beyond as a healthcare professional to invest in safety and security for communities. Really exciting. I'm Kristen from R-Zero, really helping ensure that senior care communities are considering a healthy buildings approach and helping partner with our customers to deploy that approach, really using UVC technology to provide the best-in-class disinfection you possibly could for your community. So with that, I want to turn it over to Parker and just learn a little bit more about Trilogy.
Yeah, absolutely. Kristen, appreciate you all inviting me here. I think it's a really important topic. I think that for our industry as a whole, I think that this is something that keeping in the forefront is really important. So a little bit about Trilogy Health Services. So we're about 130 campuses. Our focus is really from a resident first perspective. And so when we look at our business model, we really believe that if we are investing in our residents, the best way to do that is actually through our employees. And so making sure our employees are front of our focus and making sure that we're giving them the tools and the resources to best serve our residents, that is going to be one of our that's really our key to success. We are geographically located in kind of the Midwestern region. So we're in Ohio, Indiana, Kentucky, Michigan, and Wisconsin. We offer a number of services. We have assisted living, and so we have that in our facilities. We have memory care, we have skilled nursing, and we also offer our independent living. And so we have a broad range of services that we offer, and for most of our campuses, probably 95%, those services are offered under one roof. And so we believe it's a unique opportunity or kind of a unique pairing to bring those kind of two concepts together between a number of different service lines and our approach from focusing on our residents and our employees first. So that's kind of Trilogy in a nutshell.
Excellent. And so I think what we wanted to do is talk next about your SHIELD program, which is really in innovation. I think, can you talk to us before we lead into our SHIELD program about creating safe and healthy spaces at Trilogy? What does that mean for you as you consider both your staff, your residents, and your community at large, because family and friends will be visiting. Really, there's an extended community. How do you think about providing a safe environment?
Yeah, so we think about it in a multi-layered approach. And so, I think that, going back to pre-COVID, right, I think most of the time we kind of looked at infection control in kind of a very isolated plane. And I think through COVID, organizationally, and I think as a sector and industry-wide, we've learned a lot of lessons. And I think there's lots of lessons to still be learned. But one of the things that we look at is we look at a multi-tiered approach. So we look at what are we doing from preventing infections or pathogens from entering the facility? And that's everything from our vaccination policy, that's everything from our training for our employees on being able to identify when they may be sick, and then also providing sick leave and making sure that they feel comfortable staying at home, knowing that they're not going to be at a potential of losing a job. And so we look at that from one perspective, and then we look at what we're doing inside the facility, and we look at that again in a multi-tiered approach, right? So we look at everything from our water potential, if we had something in our water that could potentially carry pathogens, to surfaces, to air, and each one of these is multifaceted in how you approach them. And so we look at all of that inside from just a infection control perspective inside the facility. And then we also look at what do we do and what is our responses that we have in place once we're experiencing some sort of pathogen. How are we making sure we're isolating effective, and how are we managing that case load internally to a facility? And then we look at how do we get ourselves out of that situation? How do we make sure we're properly terminally cleaning rooms? And how do we make sure that infection is not going to continue to spread throughout the community? So 4 tiers, right? How do we keep it from coming in? How do we manage it before it actually takes hold in the facility? How do we manage it in the facility when it's happening? And how do we manage after the fact or after the event? So again, multi-tiered approach, and I think that the key perspective of that is understanding that there's no silver bullet out there to be able to cover that broad of a spectrum, but working across organizations and really identifying how do you tackle this one part of the time, and then keeping all 4 of those sections kind of talking to each other, I think has been a real key for our success.
And did this approach, fundamentally change coming out of the pandemic? Is this an approach that's new in how you consider managing infectious disease?
Yeah, so I think so getting in the time machine, going back to February of 2020, I think a lot of people in the industry felt really confident in kind of how we were approaching infection control. I think post-COVID has taught us a lot, right? I think that we have a lot of really smart people and a lot of minds looking at this problem. But for us, we really changed how we were looking at it as we came across. And I think that we're going to continue to see a lot of academic research and kind of continued research as we go forward, which I think is great because, I think that we were really organizationally and as an industry, we were caught in a position where we're asking a lot of questions and there weren't a lot of answers out there. And so from COVID, one of the things we started looking at was saying, how do we build the infection control program for the future? It was obviously for anybody who worked through COVID, it was a very stressful time and it was really hard to get through. But we really kind of took a long view of this and said, what can we do and how can we take this crisis and make it into an opportunity? And how can we start to build on this for the future? And so, what we're really proud of is everything we put into place during COVID, we're maintaining, and we're going to continue to do so. And that was really an approach we took during COVID to say, let's not go after snake oil or things that are just too good to be true. How do we look at the academic research that's been done pre-COVID, and how do we bring that academic research that's been proven to reduce infections, how do we bring that into a sector or an industry that has not used those kind of technologies before? And so that was kind of our approach as we came through COVID. So, and we're continuing to do that. And we're kind of, we keep our ear to the ground to understand what additional technologies or resources are out there coming forward. And we're continuing to implement new technologies post-COVID to make sure that we're ready in the future, and also keeping our residents and our employees safe, because ultimately that is our focus as an organization.
And is that how the SHIELD program was born?
Yeah. So going back into 2020, right? For as much as sometimes I wish we didn't have to go back into 2020, but from a memory perspective, going back to 2020, right? We had these things we're kind of formulating, and we understood what we needed to do, but we didn't really have a good way to kind of cement them and gel them all into one program. And so we developed that SHIELD program, which is here in front of us, and that really encompassed those 4 parts that I talked about, right? How are we managing our approach when it comes to our employees and the infection control before it potentially comes into a facility? What are we doing on a daily basis to prevent spread in a community? And then what are we doing once we've identified it, and how are we isolating, and how are we quarantining effectively? And then how do we make sure that we're really kind of nipping it in the bud once we've kind of got it under control? And I think once we really broke it down into those 4 parts and we really started looking at what our options were on the table, that really led us, quite frankly, to kind of our relationship with R-Zero. And it's been a very fruitful relationship for us, because I think we've been able to partner with you all and really find some opportunities for us as a company. And hopefully our goal is obviously kind of share this organizationally or kind of industry wide, because we believe that it's going to help everybody in this sector.
And so what you had talked about, it's really important as an organization to keep your ear to the ground on technologies. And as part of the SHIELD program, you started evaluating technologies that could help you provide, what would be best in class disinfection for you. Can you talk a little bit about the technologies you discovered and potentially how you came to UVC as a potential technology you wanted to investigate? Yeah,
absolutely. So, when we really kind of set out on this, we turned to a number of different experts in the field, and what was, looking back, it was a little frustrating that there wasn't that silver bullet answer out there, right? I think everybody was hoping that there was going to be this one answer that we could all run out and we could solve for. But the more and more I was able to kind of leverage some individuals, and they kind of suggested to me, we've really got to look back at the academic research that's been put together and the clinical research that's been peer reviewed and tested pre-COVID. And that really led us to 2 technologies that have been proven for years, decades, one of them being UVC, and the other one was ATP surface testing. And I don't want to get too much into that, but from a UVC perspective, UVC has been proven for decades to reduce infections in healthcare settings. And so when we kind of looked at it, what we recognized was it really hasn't been applied in a senior care facility or senior care setting. So we understood we wanted UVC in our facilities. And so we went to the marketplace, and we had a RFP, and we selected a product, and we piloted it, and we felt good about that product. We felt like it checked all the boxes. But once we got into our operators' hands, our operators really shared some things with us that we weren't seeing from a procurement standpoint. And so we kind of had to go back to the drawing board. And that's when we were actually introduced to R-Zero. We took a look at the product, and we felt from a number of different things, not just from an infection control perspective, hey, this is checking all the boxes. We're getting the right dosage. We're getting the right output. From a reliability standpoint, we really felt good about the physical equipment, but also from a scale perspective. 130 campuses is not easy. It's not easy to scale something in capital cycles. And so we felt really good from a procurement cycle that we could go back to our ownership and say, this is really what we want to do. And we felt like the price point for us was something very reasonable that we were able to do during COVID. And so for all the other things that were happening during COVID, that we could do that for us was a huge advantage. And so that was really what led us to the R-Zero. And then from there, we've continued to utilize it. And then kind of today, we're continuing to look at different options, primarily on the air sanitation and air quality with R-Zero to really identify how can we continue to keep this momentum moving forward with the SHIELD program.
Okay, great. Going back to that first purchase, so can you talk a little bit about what was the first layer of disinfection that you looked at with R-Zero? Like, what was your first purchase? What kinds of devices, and how do you use those devices? And then I'll ask you some questions about your key stakeholders, like the operators you talked about, because I think that's interesting to understand how to partner with operators and what's important. But just first, for our audience, what was your first UVC decision and purchase, and how are you using that technology in your facilities?
Yeah. So, and just to clarify, so we actually used it. We piloted a different product first, right? And then we felt like that was not the right solution for us for a number of different reasons, right? The operator feedback, but also from a price point perspective, we just didn't feel like that was a good fit. And so that's where we ended up finding R-Zero, and that's where we really felt like it was a really good fit. So talking through some of the decision-making processes, or I'm sorry, to talk about what it was like to use the first R-Zero, we were actually pretty amazed, right? So putting hands on the equipment was actually very relieving. It was a big breath of fresh air for us, kind of seeing a number of different products and different pieces of equipment to realize how simple it was to use from an operator's perspective. I think sometimes we don't think about this, but this is something that came out through our RFP process is those lights can be intimidating, right? We put big warning signals on them. We say, hey, can be damaging to skin. This can be damaging to yourself. It can be damaging to eyes. That can be intimidating for a first-time operator. And so making it very simple to use from a physical operation, once we get it into those environmental tech's hands, is really critical, because ultimately they're the ones that need to be using this on a daily basis. So that was a big decision-making process for us, is looking physically at the actual piece of equipment, making sure that it was something usable for our environmental technicians in our facilities. And then the other one that we looked at, which was more of kind of the academic side, was, is this product going to be able to give us the dosage that we're looking for in our rooms and not create operational issues from a timeline perspective? And so, for layman's terms, right, UVC works with dosage and time, right? How much wattage is getting put out and how many millijoules are actually being applied to a surface. And that is really critical when you're looking at the different pathogens that you're trying to eliminate in a space. And so for us, when we looked at both of those from an operator's perspective and the piece of equipment and what its output was, we felt really confident that this was the right solution for us. And so from there, we probably piloted it for 30 days. And we felt so confident, we went back to our board and said, this is the product. This is it. We found the right solution. And from there, we're kind of where we sit today.
And how does your team use, so you're talking about the ARC mobile disinfection tower, which could be rolled into any room in a facility, and it will disinfect a room 1,000 square feet in 7 minutes. So you turn it on, leave the room, it comes on and does a complete disinfection of air and surfaces. How does your team use that in all of your facilities today? Like, can you talk about your workflow, throughout the day?
Yeah, absolutely. So when we look at that, right, so and going back to the academic research, right, so what we looked at was a number of different clinical studies that were done in hospital settings, which were showing consistently the reduction in healthcare-acquired infections when UVC light was used after terminal cleaning. So terminal cleaning in a hospital is a resident or a patient has been discharged, the room has been cleaned by a technician using traditional chemicals and physical abrasion methods, and then they're utilizing UVC as a secondary disinfection on top of that cleaning. And so we took that and really built that into our model from an environmental perspective. So our process at our campuses is anytime a resident discharges from a room, that room is terminally cleaned, and then the UVC light is put into that room for a dosage of 5 minutes. And then we use it in the room, and we also use it in the bathroom. And so we do both of those because we feel like that is really critical from an infection control perspective, because you do have a lot of infection control or potential for healthcare acquired infections in your restrooms. And so we felt like that was an area that we'd have to do. The other thing we do is at nighttime for our evening shift environmental technicians is we're using those lights throughout the facility where we have high touch surfaces. So our activities rooms, our offices, our salons, areas where we know we may not be getting in and cleaning as often as we want to, but we can use this light in addition to that and to provide that level of protection that we're looking for through our SHIELD program.
Excellent. And then do you have a workflow where, there's a schedule, so it's expected that rooms are cleaned with this layer of disinfection, on a regular basis, and then the team reports in?
So that was actually another critical, and I'm glad you asked that question, because now I'm remembering back in the depths of COVID, right? Sometimes I put that in a box and put it up on my shelf. So one of the key parts that for us was really critical was being able to have the visibility into the usage of the device. And so one of the things that we were really concerned about was not getting operator buy-in and consistent use. We were able to get a Power BI connection with R-Zero's dashboard where all of our operators at the management and operation level could really see how often are they using it. And then we matched that to our emissions and discharges so we could verify, hey, if we've got 50 emissions and discharges in this facility, we should be seeing at minimum 50 usage in resident rooms and bathrooms. And then we also kind of worked with the team to kind of identify what would be a reasonable and safe level of disinfection for those common area spaces. And so we're using those in those common area spaces once a week. And so we're also able to see on that dashboard and identify where we may have a leader out, or maybe we're missing a leader at the time. Hey, we got to make sure we're able to communicate directly with the executive director to say, hey, this is something we need to make sure we're continuing to keep in place. And so that creates a visibility for us to make sure we're maintaining that level of disinfection.
Okay, great. That's really helpful. And then now that you've had this program in place, as you've added that disinfection layer, you've started to consider additional disinfection layers with different types of UVC technology. And we'll talk about that, but I want to share it through your story, which is how did you come to consider adding additional UV technology to your disinfection program? Can you talk a little bit about your decision process and what you're thinking about longer term?
Yeah, absolutely. So, when we looked at UVC, and especially for the ARC, right, and just the way that it's used, right, you're sanitizing a specific set of air, but you're really sanitizing surfaces with the ARC. And that's really the value in the ARC device, is sanitizing those surfaces. And that's really critical in our environment, from C. diff to MRSA, staph, C. oralis that we're starting to see from hospitals. It's really critical in those environments. But as we learned more about COVID, what we started to identify was really it's that 6-foot distance between myself and a potential carrier, which is you're exposed to. And that's really where we started to understand, hey, this is really the danger zone, if you will, of COVID. And so we started having conversations, again, kind of in a broad network of what other solutions are out there. And I think for anybody who was in facilities or environmental through COVID, there was a number of different solutions, right? Everything from fogging and misting to needlepoint bionization, it was all out there. And when we really started to look at those technologies and really started to try to understand, are these viable solutions for continuous air sanitation in that 6-foot radius, we really didn't see the academic research that we felt confident that we could go forward and say, hey, this is really our next solution. And through our relationship with R-Zero, they started to educate us on far UVC and upper rim UVC as options for the solution. And so that was something that we were very interested in, and we were able to pilot it at one of our facilities, actually in our Lexington area. And what we saw was something really interesting, right? So typically we'd see, during that, we still were experiencing COVID. We would typically see an outbreak of COVID anywhere from 12 to 15 residents when we were using the proper procedures on isolation. Just by the time we identified it and was able to quarantine, where we were actually able to see in that facility, we were starting to see drops down to the 6 and 7 range of outbreaks. And so we felt really good about that from a standpoint of, hey, we're not able to totally stem the tide, but we're definitely able to control it. And then we partnered with the state of Michigan. We were able to get a grant in the state of Michigan. And so we've been installing far UVC systems in all of our facilities in Michigan, which we're really excited about to start to see some of the data. And so at this point, right, kind of going back to this academic research, at this point, we're really kind of on the other side, right? We're starting to write the academic research. And that for us is really exciting because we feel like we're on the cutting edge in the industry. And I think that's really going to help continue to kind of move this ball forward, going forward into the future from an infection control standpoint.
So with the far UV, deciding that you would take far UV devices and deploy them in all of your facilities, talk to me about where you're deploying those devices and why. Like, what is the protection that you're providing in the rooms that you selected for FAR UV?
Yeah, so again, so we kind of stepped back and we kind of looked at our facilities and said, where do we have this potential for 6-foot radius infection zone, right? And where can we step in and start to reduce that, knowing that that's really where, what we saw from a respiratory perspective, that's really where we believe a lot of that infection is happening. So we focused on essentially anywhere in the campus where residents or employees are engaging that may be closer than 6 feet consistently. So we looked at common area seating, dining rooms, our offices, conference rooms, break rooms, salons, common areas, seating areas, all those areas where you're getting that kind of concentration. Those were the areas that we implemented our Vibe technology, or the Vibe technology, which I think is, like I said, I think we're really excited to start to see the results from that. But that was really kind of how we went forward on identifying where we were going to place those Vibe devices.
Okay, and those are providing, continuous air and surface disinfection, so protecting the air between two people, you and me, if we're 6 feet apart, as you mentioned. What has been the reaction from staff, residents, your community? How is your investment in disinfection recognized by your key stakeholders?
Yeah, so, and I think this is something that, again, sometimes I forget, or I don't recognize often enough how thankful our residents were and our employees were during COVID specifically, right? Just knowing that the organization is taking steps forward to do everything we possibly can. So seeing those big lights go down the hallway, not only was it a big conversation starter between our environmental technicians and our residents, but it was also a great opportunity to talk to families about our SHIELD program when they saw it when they were walking through our facilities. And so for us, I think that's a big point, right? And not only that, but our employees see the investment. And I think that is also something that sometimes we forget about, that our employees, although they've chosen to work in healthcare, they get to choose where they work. And so they want to make sure that they're going to a facility where they're not concerned about going home with a pathogen that may be harmful to their loved ones. And so for us, we got just continuous feedback from all those stakeholders, from our employees, our residents, and our residents' families. This is incredible. Can't believe you guys are doing this in the midst of COVID, and how you guys are doing this. I mean, it was really it was very motivating for our teams, and they really became invested in using them more so through those channels than, quite frankly, for me looking at a dashboard, emailing somebody and saying, hey, I've noticed that you're not using your ARC enough, right? And when I round and I'm able to see our teams in the field, they consistently tell me stories about they've named the device, the whole campus knows the name of the device, they like to see it out in the hallways and being used. And I think that in itself is a huge buy-in from all those stakeholders, which I think is really key.
Excellent. So when you think about, your disinfection program moving forward, how do you think about what you'd like to measure to determine success? Just open-ended.
Yeah.
How do you think about, establishing your success metrics, on a facility basis, on a, entire company-wide basis? What's important to you? Yeah,
so I think Michigan for us is really kind of our, probably not an appropriate term, is kind of our petri dish in this topic, right? It's really our pilot from a pretty large perspective, with utilizing the ARC devices in the rooms during terminal cleaning, but also utilizing FAR UVC. And so it gives us a good geographical region. We look at a number of different things, right? We look at the population density of a facility, right? Understanding how many other individuals may one employee come in contact with. And I think anybody that was going through COVID knows that these are very hard things to kind of measure out. So I'll just start with that. But we kind of look at that as one basis. We look at obviously our sick days from an employee's perspective, right? Thinking there may be a two-way pathogen transfer at our facilities, and how do we quantify that? We look at obviously our residents and our residents' outcomes. What is our baseline infection rate, and what is our baseline? What is our new infection rate? And so one of the things we're able to do with Michigan, knowing that we've got that entire area covered in this pilot, being able to look at other geographical regions near there that will experience similar humidity levels during the winter, and understanding what the potential for influenza is during that time. And then we also look at our antibiotic use in our facilities. How often are prescriptions going up? Are they going down? So that's one of the other things that we're looking at. So it's a number of different things, and I would be taking too much credit if I said that I'm doing all this on my own. We've got a pretty large team at this point that's really looking at all these things, and they're really trying to understand, proving out from a data perspective that these products are working.
Excellent. And when you think about like long term, you can take a look at risk. So how risk, increases or decreases based on what's going on in the environment. Also, how densely populated spaces are, if there are, for example, if there are gatherings of the community in a shared space. And then, measure those outcomes you talked about in comparison, and show improvement over time against, specific pathogens, as well as, decrease in antibiotic as a really good example of an outcome. Is that something you think about and have an ongoing dialogue with your leadership, or how do you approach thinking about planning for risk and outcomes in the future?
Yeah, so our communication with our senior leadership stakeholders, right, is very much around this topic. What are we doing going forward to make sure that we're continuing to bring in the newest technologies, right? And the reason I say that is, if somebody would have said in 2019, you should really think about using UVC in your facilities, I think, I don't know if we would have had the level of focus around this topic that we would have gotten very far. But with COVID, it became very much a focus. And I think for us, we don't want to, like I said before, right? We don't want that crisis to go to waste. And so we want to continue to kind of think about how are we pulling in new technologies going forward from an infection control standpoint, and how are we staying plugged in to the most recent academic and clinical data that's out there that's showing us what we need to be doing. And so that for us is a continuous conversation. And I think the conversation really kind of boils down to, how are we making sure that we're doing everything we possibly can for our employees and residents at our facilities to keep them safe? I think ultimately it kind of boils down to that question. And then that's really, quite frankly, my responsibility to come back to those stakeholders and say, here are our options on the board, and here is what we're able to prove out. I think where we're, from a Trilogy perspective, where we really are, and I think that our partnership with R-Zero has been great for this, is because we've kind of gotten to the point where the sidewalk ends from an academic and peer-reviewed perspective, right? And understanding that those studies take years to publish, and understandably so, right? There's a lot of data to look at, and there's a lot of data to be confirmed. Those take years. And so our conversation is, how do we continue to stay connected with what's out there so that we are right at the forefront, ready to pull the trigger when we know something is going to be really effective?
Excellent. Thank you so much for taking us through your story, how this experience started for you in considering a stronger disinfection program, how you were able to wrap it in a program such as SHIELD that could both be communicated internally to your stakeholders as well as externally to your community, so everyone has a shared feeling of safety and investment in creating safe and healthy indoor environments. It's a really powerful takeaway as how to program the work that you're doing so that it's recognized and a sense of security, I think, for everyone. I think with that, we're going to turn to some Q&A that we have from the audience. Definitely, I'm going to, right before Q&A, let's just talk about ASHRAE Standard 241, and then we're going to move on to Q&A. So as some people are aware, and people are becoming more and more aware, both the CDC and ASHRAE have released guidelines about how many air changes per hour you should have in any given room based on the average, density of that room with people. in order to provide a healthy environment. And at the beginning of July, what's really exciting for the industry is ASHRAE published a standard. ASHRAE is responsible for publishing standards that often go into building codes that encourages a higher air change per hour per room type, which impacts, of course, every type of organization that we interact with, including senior care facilities. And there's quite an increase between what's expected today and what will be expected in the future for buildings that have already been built and would be retrofitted or new building construction. So in some cases, like in patient rooms, for example, we see a 6 times increase in the air changes per hour that you would expect. Traditionally, organizations have looked to HVAC, sometimes boosting HVAC, which we saw happened in the pandemic, to increase the air changes per hour. But to realistically use HVAC alone to do that is very expensive and not ultimately effective at disinfecting air that happens in a room. And UVC is being recommended, upper air UVC specifically, as a technology that can help reach these levels. Is there dialogue in your organization around this new standard by ASHRAE 241? Like, how does Trilogy talk about this or think about this as we're at the very beginning of planning for the future?
Absolutely. So, the Plinko chip is falling down the different departments right now, right? And how do we implement this on our new construction side, and obviously on our side too, from a retrofit side. But I think this goes back to some of the things we were talking about before, right? And I think that ASHRAE is right on target here with identifying where we probably fell short from some of our infrastructure. And exactly what I was talking about, right? That 6-foot radius of potential infection happening during COVID is exactly linked to this new standard. How do we increase that turn, and how do we get potentially pathogen-filled air out of a room before it has a chance to transmit to the next person? I think it's spot on. And so I think this is something that we're obviously looking at right now. I think that we made a decision on the vibes before this came out, but I think this is going to be really critical for us to kind of understand. Okay, we understand the vibe and what it does, what happens when we start to use upper UVC light as well in these environments, and how can we potentially use that as a kind of a stepping stool to reach this new standard.
Excellent. Okay, thank you so much. More to come on how organizations are thinking about ASHRAE and also measuring how air changes per hour might change over time with UVC. So we'll definitely be posting content about that in this community at large to help people navigate. I think now we'll turn to Q&A, where we have a few questions teed up, and encourage anyone who's live with us now to ask questions. Also, following the webinar, if you submit questions to us, we're happy to answer those and have Parker chime in with his experience as well. So one question that came in, just to clarify on the Vive, someone asked, how broadly has Vive been deployed in your facilities? Is it every patient room? I think you went through the common spaces. Could you just answer that question again about exactly where Vive has been deployed?
Yeah, so when we looked at the Vive, right, we were looking at what areas potentially have a kind of a twofold expectation from sanitation, right? Not only on the surfaces, but also from the air. And where are the areas that we have that greatest risk of that 6-foot interaction, right, happening? And so we actually made a decision not to go into our resident rooms at this time. And the reason we made a decision was we felt the majority of time the residents in their room, it's probably one resident with a caregiver in that room, where we really felt like we have other spaces in the facility that may have a higher risk perspective. And I think that was kind of really some work that we did of just kind of heat mapping where people are overlapping and in the facility, and then identifying those areas to be used. I think that that's something as we go forward, I think we're continuing to learn about this and understand operationally how to implement them. And I think that's going to be something we're going to look at as we go down the road of, does this make sense to use in the individual resident rooms, or does it make sense to have a select amount of resident rooms that we may be using them for, if that's our our quarantine hall, or how are we, segregating and kind of quarantining or cohorting infections. I think that is definitely a conversation that was on the table during it. I think for us right now, we're really looking at it from a perspective of where can we get the biggest bang for our buck on reducing infections throughout the facilities.
Okay, great. Another question that came in is around how do you validate efficacy? So, you have an expectation for UVC providing a certain layer of disinfection. How do you know that's actually happening?
Yeah, absolutely. So everyone bear with me because I'm going to use some high school physics terms that we may not have heard in a while. So every watt of light produces 1 joule. So for anybody that's missing their physics from high school, just remember that. So obviously on a pathogen, right? So let's take C. diff for a second, because I think C. diff is a great example. So C. diff has a very hard exterior shell. And so that hard exterior shell is through a number of different adaptations of that cell, but that makes it really hard for chemical cleaners to penetrate that hard exterior of that bacterial cell and to be able to kill it. But UVC does a great job, but that UVC has to reach the RNA inside of that bacteria cell. And so it takes a certain amount of time and wattage. And I don't remember the exact wattages millijoules per centimeter square that is required for C. diff specifically. But what we did was we have a very fortunate kind of build out of our facilities. So a lot of our facilities have almost the exact same layout in the living area and the bathroom. And so what we were able to do was we would go into those rooms, and this is the first thing that every facility did, was go into those rooms, and we had preset the rooms to a 5-minute dosage for the resident rooms and a 5-minute dosage for the restroom. And so, 3 minutes for the restroom. So we would go into the resident room, and there is an ink card, and I apologize for not knowing the technical term for it, but you could put that on the farthest wall from where the light is. And so once you turn that on, allow that light to run in that room, that ink changes to the amount of microjoules per centimeter square that it received on that. And it will give you its dosage range anywhere from 25 to 50 to 100. And that color changes as the amount of wattage that turns into joules once it's actually on the surface has been applied. And so when we did that, we were really looking for a wattage around 75, 80, 85 would really be an acceptable range for us, because when we looked at all the pathogens that we're really concerned about, everything really kind of fell below a 55 mark and below on millijoules per centimeter squared required to kill it. And then the bathroom, we just felt like that was going to be even an area that we wanted to be even safer in. So we wanted to get to a 90, 95 millijoules per centimeter squared dosage in our bathrooms. And so that's what we were able to use there. And then once we were able to prove that, right, from our initial standpoint, we knew from an operations perspective, we were really confident on continuing to use that. And so that was how we did the efficacy test at the beginning. What I will say too is, for any operator that doesn't remember to remove any live plants, the moment you use it in a room that has a potted plant, that potted plant is going to be dead. There's no way to revive that potted plant. So that was another piece that we had to work through, is to make sure we're educating operators that anytime that there's a potted plant in the residence room, we need to make sure that we're covering that or removing it from the room before you utilize it, because it will unfortunately kill someone's potted plant.
Okay, thank you. And another question, a great series of questions here from our audience today. What are effective ways to keep the spread of infectious disease down when there are non-compliant residents? Yeah,
so this is a tough one, right? The best way, kind of going back to some of the topics I talked about before, right, is having that multi-tiered approach, right? If we're really just depending on one piece of the puzzle to solve everything, we're a bit of a house of cards, right? And so that was another part, obviously, through COVID, where we all experienced non-compliant residents. But when we looked at that, we really tried to understand how could we reduce that potential for spread from that individual resident that may be non-compliant with masking, requirements. Now, our caregivers are incredible, and so we were able to overcome that through encouragement and kind of talking with a lot of those residents. But the few that we did, right, we really looked at making sure that that individual resident's path was really identified, and then all those pieces that I talked about in the beginning were applied to that in kind of a microcosm of how are we making sure that the resident or the employees that are treating that resident are not coming to work potentially sick. How do we make sure that we're doing everything we can in that path of travel for that resident being effectively cleaned and sanitized? How are we managing that resident after a potential infection of that resident themselves? And then how do we make sure that we're getting out of that infection after the fact if that was happening? Again, super simple answer would be great. Unfortunately, it just isn't a reality in the world we live in.
Okay. One quick question just to follow up on the potted plants. Someone asked what wavelength killed the potted plants, whether it was the ARC or the Vive.
It was definitely the ARC. So the UVC, right? And when you really think about how UVC works, right? It's going to disrupt any DNA that UVC is coming into contact with. I would say the dosage we probably gave to that poor plant was probably in the 75-80 range from millijoules per centimeter squared. I couldn't give you the specifics of that one, but I do remember the phone call of Parker, we made a boo-boo. I think we killed somebody's plant. So that was an unfortunate scenario there.
Okay. Another question, rapid fire. We have one more, and then I'm going to ask you a concluding question for our webinar. So staffing is currently a huge issue throughout senior living and healthcare in general, and senior care communities. Of course, staffing is an issue. How difficult was it to get your staff to implement using ARC as part of their mobile disinfection routine? Yeah, so I think first off, I don't think we're not out of the staffing crisis yet. I think that we're all still struggling with staffing. I think to answer your question, I think it came in two different ways, right? I think to get over that initial hurdle of using it was a lot of one-on-one whys, right? Here's the reason why we're using this device. Here's why it's important. Here's why it's a value add. And then getting them comfortable with it, right? So that was the biggest hurdle to get over, is that first couple of times for an environmental technician to use our light in a facility. I think that was probably our hardest hurdle to get over, because what we saw after that was just the outpouring of support and desire from our residents, other employees, families, was so high that it became kind of a point of pride to be able to use the ARC throughout the facility, because that was something that we were really kind of putting our best foot forward on what we're doing. And that was immediately linked to our environmental team. And I think for anybody who works with environmental teams, I think we can all be honest about ourselves, is those teams go underappreciated, right? And we can do everything we possibly can to appreciate them. But the reality is in our healthcare settings, a lot of times those teams are underappreciated. And so for them to get elevated to a level of professional technicians that are preventing the spread of infections, I think was really key for kind of elevating what they do and the value of what they do in our environments and our campuses, that they really kind of, they took it upon themselves to really become invested in the owner of utilizing that tool throughout the campus. So getting them over that first hurdle was, a little bit of hand-holding, encouragement. And then once they got over it, they realized the value of it and kind of the impact it was having throughout the campus. And then it was off to the races at that point. That's a great segue to my concluding question, which is, how do you think, deploying this program, over the past months and in general, as you've deployed the SHIELD program, has impacted the role of facilities and environmental services in your organization?
Yeah, go ahead. Sorry, go ahead, Kristen. Sorry, I'm jumping at the chance to answer this question because I think it's near and dear to my heart, but go ahead.
No, so I just wanted to understand your perspective. Like, do you think the role has changed, or you're recognized differently, or contributing in a new way that wasn't evident 3 years back, for example?
100%. And I think that I'm very fortunate to be able to work with our environmental teams every day. Like I said, I think that highly unappreciated, right? And I think that we can be just honest about ourselves when we talk about our environmental teams. Is we definitely appreciate them, but I think that a lot of their work goes on behind closed doors, and kind of behind the scenes, and so they're not able to get the kind of recognition or kind of the visibility that they really deserve. What we have really seen, quite frankly, in the last 3 years, right? And it's sometimes hard to believe it's only been 3 years, but 3+ years has been an elevation of our environmental teams in discussions around resident care. And that for me is really exciting, because it kind of puts us at a table that, quite frankly, in the past, we were not really, we weren't as a part of as we would want to be. I think anybody would want to be. And so I think that it's really brought us to the table of, okay, we're having very in-depth discussions of how do we solve something that there's not a canned answer to. And there was, during that time and continued today, there's a lot of eyes that turn to kind of our side of the table to say, what can you all do to help us with this problem? And for us to be able to come to the table as operators and kind of technical experts to be able to say, here are the options on the table that we're able to solve, I think is super critical, right? I think anyone who's staying up to date is starting to see, unfortunately, see a rallis in either their senior care facilities or potentially in hospitals nearby. And as we continue to see that really aggressive fungus infection, there's really not a better answer than UVC. And so for us, when we had those conversations of, hey, we have a Sierra resident, what are we going to do? What is our protocol on isolation and cleaning and terminal cleaning? All eyes came to the environmental side, and they were really looking for answers because it was not something that they were comfortable answering. And we were right there to be able to answer. Hey, here's the dosage that we need to get to. Here's how we use it. Here's when we should be using this. And so for us, I think that really helped elevate our environmental teams to a table that in the past they really have not been included to. And so I think that's really critical for us.
Thank you so much, Parker. I think this has been, a broad-ranging and wonderful, just collaborative dialogue about your experience. And certainly your experience continues on. So we would love to do something like this with you again, where we understand once, your experience and outcomes. I think for all UVC is really interesting for this community. We'll certainly continue to take questions. Anyone can feel free to reach out and submit your questions, and we'll follow up with a recording of this webinar to everyone who registered today. Really appreciate your time, Parker. It's been such a delight to learn from your experience.
Awesome. Really appreciate the time, Kristen, and anytime. I'm happy to talk about it. I don't expect everyone to get excited about millijoules per centimeter square, but know that there's someone out there that is.
Thank you so much.
Appreciate y'all.
Take care. Okay.
Bye.
Bye.